So welcome to our discussion workshop. This is not less of a lecture and more of actual open discussion with all of y'all about the non-operative approaches to the treatment of Pectus excavatum. It's not just about the bell, meaning we're going to talk about some other stuff, but we're also going to talk a lot about the bell, obviously. How do I hit next? Do I have to go up there? Huh? I'll tell you what, you use those, I'll use these. All right, we have no disclosures, and by the end of the session, you should be able to describe alternatives to surgery for the management of the Pectus excavatum, compare the advantages and disadvantages of Pectus treatment options, those two things. We're going to quickly talk about the data around the vacuum bell in a very argumentative and angry fashion, and then we're going to talk about 5 minutes about how to use the vacuum bell, and then a very in-depth debate using all of y'all about whether or not we should be doing cosmetic options for Pectus excavatum. And we'll get into that a little bit more about what we mean when we get there. And then we're going to spend 10 minutes talking about the magnetic mini mover, which is going to be a good time. So, to begin, sorry, here, I'll just take those. Ugh. I am going to be the pro person here. Dr. Goldstein over there is very anti-vacuum bell, and he's going to try and argue you guys out of it. And I'm going to start off by saying, you know what? The vacuum bell works. We have a lot of studies to prove it. For example, you are all familiar with the St. Louis and colleagues paper from 2019 of 31 children who underwent vacuum bell treatment. To refresh your memory, they maintain a prospective database of children under the age of 21 at Shriners Canada in Montreal and at CHIO from February 2013 to December 2017. And children who were offered the vacuum bell were either too young for correction or those who wish to avoid surgery. And you can easily see here, right? Look at this difference in the depth of their Pectus excavatum. All kids, especially those who wore it more than 2 hours a day, and we recommend it 4 hours a day, had an improvement in the depth of their Pectus. How does that not work? That's good data. And obviously a lot of you are familiar with probably one of the largest studies out there, the Obermeyer and colleagues, 115 children analyzed retrospectively. Again, offered to children who were too mild of a Pectus, that they were not candidates for surgery, those who were too young, those who recurred, and those who wished to avoid surgery, and some children who had a very rigid chest wall that they wanted to loosen up before surgery began. And they used this equation that was used a lot throughout a lot of papers, which is the percent correction, which is the pretty much change in the Pectus depth over time. And you can see here, a good portion of the patients, about a third, had good or excellent outcomes. I mean, that's great. A third had fair outcomes. That's still pretty good. Only a fair had poor outcomes, meaning they didn't have much change in their Pectus. But that's almost 2/3 of patients that had some pretty good Pectus change there, Seth. I mean, look at that. How is that not evidence? All right? Right out of the Obermeyer paper. That's a good-looking Nusser pair if I didn't see one or if I didn't know better. And I know that's a vacuum bell. Here's another one out of the St. Louis paper. Again, fantastic outcomes, right? What do you think of that, Seth?
Thank you, Doctor. Okay, hey everybody, Seth Goldstein at Lurie Children's in Chicago. All right, this is going to be too easy because, you know, there's a reason that the authors of this paper pull a little tricks with the photo. That's the, in case you didn't know, that's the before on the left and the after on the right. But it went from howler of 4 to howler of 4 and change over 4 years. And my eye tells me this child might have spent his adolescent years, 13 to 17, doing it. Then if he has shortness of breath and a restrictive deficit, I have to say, well, okay, but this is now harder for me and harder for you. And, you know, you've killed a little time treading water. I want to walk you through a quick thought experiment. Those of you who use the rule track in your Pectus surgical corrections, I think I can say with confidence that the tenaculum, you get bony purchase on the tenaculum. What if you just put the tenaculum on skin and then cranked it up? Is that going to crank the skin up? And so the zealots will say, well, yes, Seth, but the vacuum bell spreads it over the surface area. Okay, in your mind, take 20 tenacula and put it on the skin and crank it up, and what you get is a nice degloving without elevation of the sternum. And we actually know that to be true to some extent. For those of you who haven't seen this, these are sagittal CT sections of a before and after, and I'm sure the photos are plenty impressive, but you can see not a bit of sternal elevation and a fair amount of sub-Q tissue deposition is what the vacuum is achieving. So my bottom line, and I'm going to yield the rest of my time back to Dr. Gulak, I simply have not seen ample sequences of before and after photos in which the before suggested to my eye that a child would benefit from correction, while the after did not. And that's not to say I'm a reasonable guy. There may be children for whom the vacuum could work, but they're either too young or too mild for the surgical correction I'm considering. And I would suggest to this group that you're never going to be sort of equipoised between one or the other. I'm sorry to do that to you.
I know you wish there was a mic here to drop, but unfortunately there's not. Well, Seth, I'll tell you what, how about we meet in the middle somewhere? Maybe some kids have some benefit, some kids don't. Maybe it's the younger kids who have benefit. Maybe it's the kids who have smaller amounts of defects that might have more benefit. And I think that we all know this Toselli paper, which really did demonstrate that when they looked and broke down who has a good or better outcome for a vacuum bell, who's unsatisfactory. Age and the initial pectus depth are obviously very good predictors of who does well. All right, so maybe certain kids might benefit, some might not. So we said that we talk a little bit about how we actually use the vacuum bell, just for those who might be trying to build their own experiences with it. There are a number of papers out there. A lot of them initially use specific pressures when they were actually trying to say how much you should pump the bell up to. But a lot of them actually move now, and we don't use that anymore. We just go by the subjective feel for the patient. This is our protocol that we put together over at Shriner, Chicago. We do it for kids who have a very mild pectus, don't meet criteria for surgery, or they're too young for surgery, or they recurred after surgery, which would never happen to me, but could happen to me. We take a measurement, very specifically, most importantly, looking at the diameter between the areola. It's very important the vacuum bell does not overlie the areola. Otherwise, you might end up with some kind of gynecomastia. And then the real problem is that, and I don't know if has anyone out here had gotten insurance to pay for the vacuum bell? Oh, okay, you might have to come up and share your experience. I fought, I begged, I pleaded. I asked Shriner Chicago from the bottom of my heart to please buy some vacuum bells. They won't do it. And so we tell patients this is a possible therapy for you. You don't meet criteria for the NUS, you don't want the NUS. What I do is we measure the chest out, and then we say what size vacuum bell they should get. And then I offer them a list of possible places they can get it. And I go, you can go from the cheapest, and if it fits one of these one-size-fits-all there's a company, I think, in Russia and another one elsewhere in Europe, then go for it. And if not, obviously, you can reach out to Eckhart Globe, buy the bell yourself, and bring it back in, and I'll show you how to use it. When we were prepping for this talk, Seth pointed out to me that based on a quick Google search, as of this week, you can actually buy vacuum bells at walmart.com. So now, and they come in 6 sizes. So you guys can actually now send your patients, and it's only $200. I'm not sure of the quality of these. I have had patients come back with the cheaper ones they got from Russia, and so they ended up having to go buy the real ones from Eckhart Globe anyways. But it is also a possibility to buy it there. Once they get the bell, we have them come back into clinic, and we do a very simple increase in the duration of time. Always the same amount of pressure, it increases over time, but until they feel a good lift in their chest, but it's not causing pain. And they start at about 30 minutes twice a day, moving up towards 120 minutes twice a day over the course of about 22 weeks. And then we stay there until they feel comfortable with their correction or they give up and I get to do a NUS. We have a vacuum bell here. I think, Sung-Hoon, do you have your vacuum bell?
Yeah, right here. This is not the vacuum bell made by the German company Eckhart Globe, but it's similar function, and basically you put it on and you pump it, and you can get the effect.
Yeah, and it fixes. All right, so this is the real reason we did this talk. So Seth and I were talking, and I wrote a paper recently with one of my residents that we have other options out there. We should start working with our plastic surgeons and come up with other, for kids who have merely a cosmetic benefit and don't have a physiologic impact. There's no alteration of their PFTs, their echo is normal. Why can't we do a cosmetic surgery in order to make them feel better about their pectus excavatum, reduce the psychosocial impact of having pectus as a child, and help them out? And Seth said to me, what did you say specifically? I think he said, we're not plastic surgeons. Yeah, we drive nicer cars. I think it's something along those lines. And I said, well, you know what? That's a really interesting question. Should we be offering to fix Pectus excavatum from a cosmetic standpoint only? And these can include things like autologous fat grafting and hyaluronic acid injections, and possibly the vacuum bell, if you believe Seth. So I think this might be the first time this has ever been done at APSA. I'm hoping this works. You are now being included in a live research study, all right? If you do not want to be involved in the study, you don't have to be. You will not be identified. But we are going to have a debate, and we are going to debate the pros and the cons of treating patients just for cosmetic purposes for their pectus. And we are going to take this debate and record it. We're going to transcribe it. We're going to put it through NVivo, which is a qualitative software platform, pulling out major themes of the debate. And we are going to publish the results of our debate in JPS. They have not agreed to it, but I'm going to force them. I'm going to ask nicely. So yes, please, if you're against being involved, just don't speak, or you can step out. But otherwise, we're going to record this session and do this. And we already have IRB approval for this. And at the end, we're going to do a quick poll and see what people think. So I invite any of you who feel strongly one way or another to please step up to the microphone and tell us what you think. And I should mention this very quickly based on my IRB told me I had to. As participants in the study, by remaining here, you're consenting to your involvement. If you would not like to be involved, you may feel free to leave or just not talk. The only risk to you is a loss of confidentiality, but no participant will have any identifying information recorded, nor will the recording itself be made public. There'll be no direct benefit to you, but the benefit will be to society as a whole. All right, what do you think? Nobody? There we go.
Do I not say my name?
No, you don't have to say your name.
Okay. I feel pretty strongly that cosmesis alone should not be offered for two primary reasons. First of all, it depends how many people in the room actually care for adults with this problem. Because I see a lot of adults in our practice, and what I've noticed is that the patients that come in their 30s and 40s almost invariably never had symptoms until they got older. So I think correcting it cosmetically, we say there's no long-term cardiopulmonary impact of the pectus, except the way I look at it is that when patients are teenagers or even early 20s, they're pretty much at their maximum potential for physical fitness and physical stamina and physical ability. And what happens is, as all of us get older, every decade that line drops to in your 20s, your 30s, your 40s, and at some point that intersects with the physiologic effect of your pectus. So adult patients become symptomatic fairly suddenly later in life. And 35-year-olds come and say, I used to be able to run 5 miles a day, and now I can't run, I can't walk 3 flights. So I think that's the physiologic reason. The second is because I think with the development of new hardware systems, we have incredible opportunities for the aesthetics of the chest wall. I'm speaking specifically about Dr. Park's system, which I've been using for 2 years now. And I think everybody here is probably familiar with the concept of the lateral bridging bars, which creates incredible stability in the cage structure, which allows what Dr. Park calls the compression strings, or flare busters as he calls them. And I now put anywhere from 1 even to up to 7 subcutaneous compression strings using number 5 fiber wire, and I have been absolutely astounded by the results that we're getting from an aesthetic standpoint, to the point where even minor imperfections, really anywhere on the chest, not just the costal flaring, which you all know is the #1 complaint after the Nuss procedure. Everybody wants to know if the costal flaring is going to get better, and it doesn't. But that is virtually completely treatable with this new type of hardware system. So I don't see a role for any of these type of plastics procedures for those 2 reasons.
I think your first point's very interesting about if they do need a problem later become symptomatic, and you've already done something, now you're going to have other issues to deal with there. Yeah. Yes.
Yeah, I think there's 2 reasons to fix a pectus. One is the physiologic symptoms. The other is the patient's self-image. So whether you want to say cosmetic or all that, but self-image, and we've published papers 20 years ago. We've been doing this for 30 years. So from a cosmetic aspect, that is equally as important as long as they meet the criteria. I would never offer anybody surgery who has a Hallor index of 2.6 and has no symptoms. But if somebody has a Hallor index of 3.2, doesn't like how it looks but feels good, absolutely, that's totally appropriate. There's lots of plastic surgery literature where they put implants to fix it. I think that's the worst thing to do because there is truly physiologic deficits with a Pectus excavatum, and all you're doing is hiding that, but you still have the pressure on the heart. And there's Becky Brown's, Phoenix, there's Norfolk, there's tons of evidence. But from a cosmetic standpoint, if you're going to say fixing it, I could also comment on the vacuum bell. Vacuum bell works, but the patients have to know, in the best case scenario, it's going to work 20%. That's in a 9-10-year-olds. But there's zero risk almost if they use it properly. But definitely for self-image, this is totally equally an important reason to do it.
Sharif Emil, Montreal. I have no problem mentioning my name. So as you know, we run a very large chest wall center, actually Canada's largest chest wall center in Montreal, and you quoted our papers on both sides. I would agree and disagree with John. I think we do not know what happens to these adults, but data is piling up that they do likely to become more symptomatic because lung function does not continue to increase for life, and there are more and more studies coming out that showing that adults can become symptomatic. So I think that's a great point. But I also have absolutely no problem fixing a Pectus or offering treatment, whatever treatment you want to offer, for what you call cosmetic. I don't believe it's cosmetic. I mean, we don't call a cleft lip cosmetic. You can live with a cleft lip your entire life, but nobody would call that cosmetic. This is a chest wall anomaly. It's a deformity. And when you see these patients before and after, and this is just not anecdotal, there's been a lot of psychological testing done and so on and validated studies done. These patients, their lives change. Their lives change. And whether they're able to do more because you've improved their physiology or they're suddenly confident and they want to do more, it's a life-changing procedure or intervention. So in fact, we stopped doing pulmonary function testing after we found that it does not change the decision because 90% of our patients just do not like their body image and they want to change it. Now, with respect to the bell, I'll just say one thing. The bell does work rarely. Okay, so actually the conclusions of our study is that we offer it to the patient. It's a shared decision making and there's no harm in trying it. But most patients who really seek a correction end up getting a NUS procedure.
Yeah.
John Doe, Earth. I would agree with most of what everybody else has said. I think that the image of self-image, it's hard to assess a self-image in a 7 or 8-year-old to whom you're not going to offer an operation, but you might offer a non-operative intervention. But certainly an adolescent is forming her or his or their self-image, and it is something that I think you have to strongly take into consideration. A word about the vacuum bell. We've been using it for a little less than 5 years now. And one of the lessons learned is that the shape of the chest makes an enormous difference. A deep funnel-shaped Pectus, such as the one that's in the picture, is not likely to do very well with the vacuum bell. But a sort of scalloped saucer-shaped chest is a good candidate for the vacuum bell used properly. The third thing that I would say is that I would disagree about the flaring. We have patients who have had NUS procedure, and at 6 months I start them on vigorous core exercises. And in almost every case, when they do the exercises, as they grow, as their chest remolds, they lose the flaring. And they notice it, and their parents notice it.
Thank you. I just am here to echo what most people said. John, I agree with you. I do take care of adults as well. And I always ask, what was it like when you were a teenager? What was it like in your 20s? And I hear that over and over, that they just didn't seem to have much in the way of symptoms, but they all came later. So I would agree with that. As well, as far as cosmetic, there might be a child who has a significant deformity, might consider it cosmetic because they're not having symptoms because they're not active as well. But motivated, they have indications for operation, they have it done, and then all of a sudden there's this new physiologic change that they're aware of. I've seen that as well. And you had just mentioned when you posed the question, maybe you weren't being complete about all the variables, but PFTs, normal echo, the number of times I've seen normal PFTs and a normal echo, and yet they're sort of borderline in their measurements. I send them for metabolic testing, and sure enough, they have a significant decrease in their VO2 max, and likewise, they could be 110% of predicted on those studies, and it makes me, okay, I'm not going to be able to help you much with the NUS procedure, but it's been very helpful when it goes the other way too. So an echo that's normal and PFTs that don't show any change, those I don't find those as important or helpful. So.
Hi, I'm Farouk Demary from Boston Children's, and thank you for putting on this session. This is so fun to listen to so many experienced Pectus surgeons talk about this. Similarly, I'm not adding that much, I'm just echoing some of the prior comments, but we've been using the vacuum bell for about 4 years. What I want to say is that I wouldn't consider the vacuum bell a cosmetic necessarily. It's just a different way of treating the chest wall, as if it's efficacious. And the question is who it's effective for, as opposed to fillers and things, which isn't actually changing the shape of the chest wall. Now there is a paper out there about how the vacuum bell may just thicken the sub-Q tissues of the chest wall. So I could see the argument: is it actually changing the shape, or is it just thickening the tissues? Which I think is a good question. We've seen it help. I agree. It doesn't work all the time, but the key thing is compliance. We've looked at our experience with it, and we're going to put this together, but it really makes a difference. If a patient wears it 4 hours a day, 7 days a week, compared to even 4 hours a day, 6 days a week, huge difference in results. Like, you really have to be compliant, and that's a lot to ask. So the way we generally counsel our patients, like, vacuum bell, you do the work, NUS, we do the work. And to the prior comment about patient self-image and age, that's so important, because we have a number of families who come and see us, and parents want, the vacuum bell, and the kid's 9 and they don't care. And the concept of assent for a child is so important for this, because this is not something that we want to send a parent chasing their child around the house wearing a vacuum bell every day. So anyways, those are my comments.
That's good. Thank you.
Hi, I'm Ellen from UW-Madison. I just wanted to echo what 2 speakers have already said. One is that our center doesn't look at this as a cosmetic procedure. We think of it as an abnormal condition that we're giving more normalcy to. And the doctor I work for uses an analogy. We're not doing like a breast enhancement or making your normal natural born nose look different. This is either an acquired or a congenital condition that we can correct. And the second thing, in terms of the rib flaring, that's something one of our physical therapists noticed several years ago, and her working along with some postural experts in the country, and then along with actually the brace manufacturer for the Pectus brace in Argentina, she's crafted this core exercise training program, and we're getting complete resolution of rib flaring, a lot of scapular shoulder asymmetry, and it's been really successful. So if we have a little kid like less than 10 who's not yet a candidate for surgery, we'll enroll them in PT for usually 6 to 12 months. And if it's a mild or moderate defect, we can get complete resolution of the defect and their posture problems.
When do you start that? Is it after the NUS bar is removed, or?
So we offer it as like a sole treatment for Pectus excavatum if it's a mild defect, and then any patients getting bracing for carinatum or a NUS bar for excavatum, they're all enrolled in this PT program.
Thank you.
Gene McGarren, University of Virginia. I just want to follow up on that last comment and the cleft lip comment. I think the term cosmetic really is a misnomer in this scenario as well. The term I use for parents and patients is corrective therapy. And in fact, I use the cleft lip example to them to kind of make the distinction between what I would consider correcting anatomy to a more typical appearance. As I say to the parent, I try to avoid normal, abnormal kind of thing. And but the other thing, so I think that's really important. I also agree that we don't do much in the way of PFTs because most of those kids are going to be normal, even if they're having symptomatology. So I agree that a lot of these kids are their own baseline if you really can trust what their history is. The last thing I want to say, though, is when parents come in and children come in, or youngsters come in, I really challenge them to be honest with each other and with themselves, because occasionally you'll get the parents saying something like, well, they just care how it looks, but if it's just cosmetic, we don't want to do it. And the child is there kind of looking down, like, with their eyes down. And I really challenge them both to be honest with what they feel, especially the kids, and for the parents to be open to what the kids are telling them. And the last thing is that on my first visit with these patients and parents, I tell them, I don't want you to make any decisions here today. I want you to go home, think about all these things we've talked about, and then let's have another talk sometime. So I think there is a lot to the self-image psychological aspects. And you've also all had the parents who've come in who never got repaired and said to you, I never want my kid going through what I went through. So just a few of those thoughts.
I'll make it brief because hard to follow, Bo, and agree with everything that's been said. And I learned a lot, so thank you for bringing this up. I'm going to really ask questions about the core exercises. I think that intrigues me. As far as non-operative with the bell, I've had patients come in and say, look what I can do, and they Valsalva or do something, and they pop their chest out. It just doesn't last. So I think that's how there's some legitimacy to the bell, and it works in select patients. And I do agree with the shape types that it'll work on. And then finally, for the rib flaring, it does get better over time. I'm interested in the core, but we've modified our Pectus carinatum brace to make it a rib flaring brace that we use post-operatively, and that also works for really significant rib flaring. Thanks.
I think we're going to have to do a separate rib flaring session on that because it was actually going to be part of this, and for time management, we got interested in this part of it. We cut that part, but it seems like maybe next year we should just have a full session on how to deal with the rib flaring. But yeah, continue.
Yeah, hi. Frank
More about the cosmesis if you can.
Frank Margaron from Children's Hospital, the King's Daughter. So just wanted to comment that just because we have a normal echocardiogram and pulmonary function testing, that doesn't necessarily translate to no functional deficit in those patients. Many of us have had 15-year-old, 16-year-old patients that are on the high end of athletic activity and pulmonary, cardiopulmonary endurance capabilities, and just because they fall in a normal range doesn't mean that they don't have a deficit from where they should be. And one thing that hasn't been mentioned is, as far as cosmetic repair, what time frame are we looking at in regards to pediatric, application? Because as we know, this is a progressive phenomenon that occurs until chest wall maturity. So if we're looking to say, hey, this is cosmetic now, it doesn't mean that we're catching that at the trajectory or at the time frame where we're not going to see compromise or limitations later on. So if we're advocating for cosmetic repair in these patients where they actually do have a functional limitation, even though they don't specifically measure within the pulmonary function testing and echocardiogram, we're essentially giving power to the insurance companies that I'm sure we're all aware of that want to deny needed surgery for these kids as well. So.
Just sorry to be up again, but just to follow up on Frank's comment and the comment that was made before, we've had two patients who have been near world-class athletes, and both of them, as they developed Pectus, had a demonstrable loss of stamina. Their coaches saw it, they saw it, and yet on their exercise testing and their pulmonary functions, they were still at 100% of predicted, but they started out at 130% of predicted. So when the insurance company looks for an 80% loss, they actually had more than an 80% loss from their baselines. And if you're looking to get those children improved, writing a letter documenting that, and then if necessary, a peer-to-peer might help you. It did in these two cases.
So no one's stepping up to the mic. We're getting close to the end of the time for this part.
Hold on, one more here.
Hi, Seth. Welcome back.
Well, it's because I agree and emphasize all the benefits of surgical correction in terms of current or future respiratory deficit and psychosocial, but I just want to revoice a vociferous objection that you've already heard me say. Remember, your initial question was, beyond surgical correction, should pediatric surgeons offer these things like fillers and fat transfer? And I think we've heard that we fix the Pectus for a lot of reasons, but for the transcript, I just need to say that, I think our image is treating sick children, and we don't have the time, infrastructure, or training to open very complex ethical issues about things that are done for just appearance, like getting Restylane for your. I think I trust the people in this room to do the right thing and help children in a sensible way. But this slide you've been looking at the whole time is a before and after and a slice of the CT showing you the silicone or saline implant that's doing so. And hopefully that's as horrifying to you all as it is to me. And so I just wanted the record to reflect that.
Seth, if you don't want to do it yourself, you can send them over to me. I'll take your RVUs. I'm okay with that. Yes?
So I got a comment on that. Mike Gretzky, Norfolk. We have a huge experience. If anybody's going to be in England, Bob Obermeyer is presenting our follow-up data on vacuum bell, which, hate to say this organization rejected that article. But vacuum bells work. As surgeons, what we need to know when to operate, when not to operate, but also offer options. The vacuum bell is a great option for little kids who you're not going to want to operate on. And even for severe ones, there are kids, I have patients who I don't want an operation and you got a Howler index of 5. It's only going to work 10% if it's a 16-year-old, absolutely. But it's not 0%. And this is something, and I'm honest with the families, there is no way ever to do this research. There's no way ever to prove this. But I have to say, anecdotally, and it's fully anecdotally, it's judgment, I fully make all the caveats to that. All the kids that have failed vacuum bell therapy, failed in quotes, that went to the operation, they had the easiest postoperative thing because I think they're flexing their chest. There's no way to ever prove that, and I'm honest with that. But I think just like all exercises, the kids who exercise it, they're home post-op day 1 and 2 with much better pain control because I think of that flexion. So it's another benefit that there's zero way ever to ever prove what I just said. But the vacuum bell works. It's low percentage.
All right. In the interest of time and letting Sung-Hoon get to his part of this, I'm just going to move forwards and ask you to do a quick poll. So this is going to be on Poll EV. You guys have been used to it before. It's a little bit different. It's not the same name used before. It's the BG363, Brian Gulak. I'm going to have you sign in there on your phones, pollev.com, BG363. Should pediatric surgeons offer cosmetic options or even make patients aware of these options if they do not have a physiologic impact from their Pectus? Which is a little bit, sounds like some of you are saying that they have a physiologic impact, you just can't see it on an echo or PFT, but hey, there we go. Keep answering. I'm going to let Sung-Hoon come up, who's going to tell you about the magnetic mini mover. Just give me a second to scroll. Do you need slides? Oh, for a second. You want to be on the next? And please, even if it goes beyond, keep answering if you haven't answered yet, because we're going to record this poll for our final analysis of this study. Yep, just the green.
Okay, I'm going to talk about the next big thing in Pectus excavatum repair. This device is not my idea, but from Dr. Harrison, who's in attendance over here. As you know, he's considered the father of fetal surgery. It's his first passion in surgery, pediatric surgery, but his second passion is to fix things with magnet. And this is one of the magnet idea that he's been trying to develop. It's called a magnetic mini mover. And as I mentioned, he came up with the idea in 2008, and a patent was obtained by the Regents of the University of California. And he set up a company to develop this. The company is called Magnets and Me. And I think this is one way for a surgeon to, if they come up with an idea, if they want to develop it, to set up a company to develop it. So the concept of the device is to have an internal magnet that's bound to the sternum, and then you have an external magnet that's going to apply the magnetic force to pull the chest, the sternum forward. So there are two components. The inner component is called the magni implant, and the external brace component is the magnetract. In the past, there were two iterations. The first was a screw-on design, and then the second one was a wire-on design. But these designs were not that effective, which was found out by a trial that was done later. And this is a picture of a external brace that the patient puts on. You don't need a brace to put on. It just magnetically gets attracted to the skin, and it's held on by magnetic force. So there are two trials. Trial number one involved 10 patients, which was performed at UCSF. And then trial number two involved 25 patients done at UCSF and Davis and then Kansas City. And the result of the trial was that the few implants during these trials were breaking, especially the ones that was used to using a wire to go around the sternum because of the movement of the breathing. They were fracturing the wire, and then the implants were breaking. But the results were good in young patients between 8 to 11, and but it was not that good for asymmetric deformities. The result of the trials was that the FDA did not give approval for the implant because of the breakage of the devices. So the current status of the device in 2016, a second phase 2 SBIR grant was obtained by the company, and a new device was designed. In 2020 to 2023, IDE, Investigational Device Exemption, was obtained from FDA to start a new trial. But in 2023, however, the company failed to obtain the phase 2B grant from the NIH, and due to lack of basically industrial or venture capitalist support. The new design of the device looks like this. There's nothing to break. It's got screws, and you put it on the sternum after you make an incision. It's a snap-on, it's a clip-on, and you could imagine that this device will not break. A proposal. We need to do a new definitive trial. It would involve 3 centers, 30 patients, 10 patients per institution. The targets for the patients will be between 5 to 11 years old. The reason for this, we believe, is that when this device is applied to young patients, they could be fixed in 3 months, I suspect, because of the appliance of the chest. And then these patients, I think, once they're fixed when they're younger, they will not need to get a nose procedure when they're older. So in order to get this device approved, we need to do a trial. So I'd like to put out a petition to pediatric surgeons. Maybe perhaps they could sign this petition to suggest to the companies that sell implants to perhaps sponsor this implant so we could have this device as another alternative to surgical treatment of Pectus excavatum.
Any questions for Sung-Hoon?
Yes, you remove the xiphoid.
Yep.
I'm sorry? I think it's going to depend on the compliance of the chest. So for the young patients, I think that they could probably be fixed in 3 months.
Any other questions? Any last comments about anything related to Pectus anyone wants to get off their chest while you have a great captive audience? All right, with that, we'll end early. The new technology group that put this on is now putting on 2 separate sessions running back-to-back, one on robotics, which is, I don't remember where it is, and one on ChatGPT. So if you enjoyed this session, make sure to check out one of those 2 sessions. Thanks, everybody.